Today we're going to talk about the report that I presented to the membership that convened at St. Mary's Legacy Clinic at the regional meeting sponsored by Blue Cross Blue Shield of Tennessee. And I'm sorry that we couldn't all be together. That certainly would be preferable, but this is a new way to think about communicating. So let me know what you think about it. So first I want to start with what Mahatma Gandhi said so eloquently, which is be the change you wish to see in the world. And the point I want to make here is that TCCN members and their partners are being the change we wish to see in the world. And the amount of gratitude that I feel, and I know Sarah feels, and others who have the pleasure of partnering with you and serving you in whatever capacities we can feel is profound, because you are out there in the front lines doing the really hard work of serving people who others are not serving and who are often difficult to serve. So thank you for being that change. Today we're going to talk about membership growth, what I've learned in my reflections in the past year and a half, why evidence matters. We'll talk about the safety net, and we'll talk about our advocacy strategy, including some updates and conversations about hard topics. In terms of membership, we've been blessed with 12 new members, an increase of 30% over the last 12 months. So we have a total now of 51 member clinics with locations in 28 counties. And you can see we have a wonderful mix of medical and dental, medical only and dental only. I believe we could probably grow another 10. I'd love to grow everybody that is out there and invite them in under the big tent that is TCCN, because we exist to support all providers of free and charitable care that meet our 5 criteria. So how did I learn what I've learned that I'm going to share with you? Well, part of it is that I've had the pleasure of visiting with you. I visited about half of our clinics, and I don't have a budget for travel really, but I would love to secure one so I can visit the rest of you. It's a really important learning for me to see you and to see your patients and your providers and your programs in your communities. So if I've been with you, thank you. And if I haven't, I'm looking forward to coming. We have a number of profoundly important and helpful partnerships, and I learn a lot through our partners. And I try to bring to you everything that I'm learning as quickly as possible, because knowledge is really powerful, and we need that little engine that could, and we need all the power we can get. Also, I learned a lot through the strategic planning process that we had to create our 2018 through 2020 strategic plan. We surveyed members, and we surveyed funders, and we surveyed board members, and there was a lot of learning there, some of which I'll share with you shortly. As well, we learned through advocacy work, specifically how powerful the relationships that you can build with your legislators are in creating a field of possibility for change. It really all starts with that relationship, and we're going to be building on the relationships that you have, as well as making a lot of new friends, because we've had a lot of turnover at the governor's level and as well the legislature. I've had the pleasure of learning from other leaders, both at a state level and nationally. And part of that was because of the opportunity I had to participate in a national program called the Roadmap to Health Equity. I represented TCCN in work funded by HRSA and guided by AmeriCare's University of Chicago, Loyola, in the form of Dr. Julie Darnell, and the National Association of Free and Charitable Clinics. So I've really had a great education, and now I'm ready to tell you kind of what I'm seeing and what it means. First of all, I'm pretty clear that there will always, always, always be a need for free and charitable providers. And that is because the needs are so complex. So even in the states where they've expanded Medicaid, what we see is that unmet needs are being addressed by the providers, whether it's mental health, whether there's a shift somehow in the mission. And often there isn't a shift. They simply keep providing the care they were providing because they're preferred by their patients. The community trusts them. There aren't enough doctors. Just because you have insurance doesn't mean you get to go to a doctor. So if you have a free and charitable clinic that you can go to, you're a blessed person, and that blessing will continue whether there's Medicaid or not Medicaid. But that said, even though the need will always be there, the viability is not assured. And that's particularly true at an association level. I've gotten to know my peers across the country. There were, I think, 23 of us when I got to know them last year, and there are 20 now. 3 having closed because they can't figure out how to sustain funding. And we're going to talk a lot about that. But the bottom line is, for you as members providing free and charitable healthcare services, or for us as an association and a partnership among ourselves, we have to stand out in a crowded not-for-profit field. All of us can think of hundreds, if not thousands, of really wonderful not-for-profits in our communities and in our states and in our nation. So why would a funder choose to fund your program or our program? We have to have a way forward that allows us to be bright in a field of brightness. So that means we have to define and support our value proposition in a very crisp way, and we'll talk more about that. But the big question that I'm bringing to you today is, are we ready and willing to prove our impact? Because I think this is the point in time where that is the path forward. So we'll talk about that next. But the first steps is to recognize that supporters want evidence. And everybody wants to know that what they're providing makes a real difference to those they've provided it to. So how do we begin? Well, we start with members who are ready and willing. A number of you are collecting and looking at data now, a large number actually. And so from our data capability study, we know that the vast majority have an EMR, which really facilitates this data collection and reporting. It doesn't preclude folks that are using paper and pencil from participating, however. So we start with those who are ready and willing wherever they are. And we select 1 or 2 health measures that we're going to measure the same way and report the same way, and then review together. The 2 measures that I'm most interested in seeing us move forward with, partly because they are applicable across our medical and dental providers, and partly because they mirror the national move that I've learned about and been participating in as part of the roadmap to health equity, are blood pressure in the form of target BP and screening for major depression. So we'll talk more about that. Perhaps not in this meeting, but we will. And the next step is for us to adopt a standardized protocol for each measure. As I said, I know one exists for target BP, and we implement. We begin working through the logistics of sharing this data, looking at it, and we learn, and we'll have room for improvement every step of the way. There's nobody who goes through this that doesn't find a lot of room for improvement. So we will be finding that together. And as we take these steps and have our learnings, we'll grow the initiative slowly across the membership. The great news is that we are not the first to do it. There are a number of other states that are making these steps, and North Carolina is a particularly fortunate state because over the past 12 years, they received $20 million from Blue Cross Blue Shield to begin tracking and reporting data. So that is the great news. Others have blazed this trail. We don't have to figure this out ourselves. We have partners in the field. If you look at this uncontrolled diabetes slide, what you want to see here is that a lower percentage is a better percentage. We're looking at the comparison between North Carolina's free and charitable clinics with HRSA centers being FQHCs in North Carolina, and then Medicaid HMO providers in North Carolina. Lower is better than higher because we're looking at the most recent A1C greater than 9%, plus no A1C test performed. So looking at a population that is known to have high blood pressure, and then these are the results, and these are great results. The free and charitable clinic is actually, sector in North Carolina is doing a better job than the benchmarks that are provided here. This next slide is actually, you want the taller or the bigger percentage to rule here, because you're looking for the percent of the population where the blood pressure was controlled at under 140/90. And again, you see the result is that the North Carolina Association of Free and Charitable Clinic members had results that were superior to the other two types of providers. And this is surprising. But again, this has been 12 years of work, and they have really grooved in on what they need to fix to be effective. And I believe that all healthcare providers can probably learn from the model and the example set by North Carolina. Certainly we can in Tennessee. So we need to build our body of evidence. And there's a model out there already called collective impact. And it brings people together in a structured way to achieve social change. And this is really the model that I'd like to adapt for TCCN to begin our work here. Essentially, you have a common agenda, which we do. We exist to provide healthcare services to low-income, uninsured, underserved, and underinsured people in Tennessee. Specifically, though, we can focus in on reducing and controlling blood pressure among our patient populations, as well as identifying and either treating and referring major depression in our population. The shared measurements are the ones that I noted before. Mutually reinforcing activities. Those are things like working together in a shared data environment, reviewing information together, looking at best practices, going through trainings, and continuous communication is what I think TCCN, in the form of myself and Sarah de Betancourt, try to provide an open link, an open door always, trying to share with you what we're learning and hear from you what you need so we can address it. All of that is supported by what's called a strong backbone, and essentially that comes to TCCN in the form of myself and Sarah. So this model exists. It's well understood by most funders. It's what's used to decrease disparities, health disparities, social disparities, because they're complex problems. Well, our population has nothing if not complex problems, and so we're going to adapt this model to our own use. So how do we get from where we are, where we don't know much about ourselves as a network, to where we need to get to, where we can explain to funders and volunteers and community partners the value and show them the value of the work we do in the community with them? Well, the first step we're going to take is mandatory annual survey. It's due at the end of November. Everybody should have received an email about that, and if you haven't, please call me or Sarah. This is really descriptive information about your programs. When we go back to the legislature this year, we would like to be armed with information about who we serve, how you're staffed, how you're funded, what programs you provide. So many things that we've had in a sort of minimal way, but we have asked you to complete this survey, which includes no requests for data that we can get someplace else. So it's a pretty easy survey. Many of you have completed it already, and thank you. So that's mandatory, and what that means is if you aren't willing to give TCCN basic descriptive information about what you're doing, you won't be allowed to vote. You won't be allowed to be an organizational member. That doesn't mean you can't be part of TCCN as an associate member, but there are certainly benefits that come with being an organizational member that are superior. And so if you would participate, then you'll keep that status. The second step to implementation is voluntary accreditation standards. These we've adopted from the National Association of Free and Charitable Clinics. They are very basic, and when we ask you to renew your membership, there will be a survey that you step through. with items such as, do you have a board? How often does your board meet regularly, etc. Very basic things that all you have to do is let us know where you are, and then we'll let you know how that compares or what level of accreditation you've already achieved. So essentially, I think everybody will fall into an accreditation level, and they'll probably be silver, gold, titanium, I don't know. And we'll let you know where you are. And then just by the process, you'll have learned what steps you need to take to advance to the next level. And we'd be glad to support you in making those steps if you're ready, or that's an organizational goal for you. The third is this phased data collection and reporting. I'd like us to get going in January because it's not rocket science. And the sooner we start learning, the further down the road we'll be toward transparency and accountability and all kinds of wonderful benefits that come from that. So those are the big steps to implementation. This is actually a very cool slide that you're not having the pleasure of seeing doing its wonderful flying in and flying out animation. But as you know, our vision at TCCN is to create a stronger and more compassionate safety net for all Tennesseans in need. And the point of this slide is that I've added through partnerships. First of all, I want all members to see themselves as partners. We're not big enough to be anything but partners in the same boat trying to pull forward together. So we're partners, but we're also supported by tens of different kinds of partners. These are a few of them that show up on the screen. We need our partners. They make us better. They pull us forward. So we're very grateful for that, and that's how we'll come to realize our vision. So this was one of the questions we asked in the 2017 member survey about collecting and sharing statewide aggregate data to TCCN member organizations. The way this particular question was framed, it was that we were going to report back to you. I think that is less powerful than collecting and sharing statewide aggregate data on behalf of TCCN members in support of their missions, which is what I believe we really want to do. But you can see that back in 2017, for the 19 members that replied at that time, and we only had, I think, 23 or 25 members at that time, this was not universally embraced. 53% thought it was very important. 21 thought it was non-negotiable, must have, but 21% also thought it was just moderately important. So there's not, at that time at least, there was not consensus on the importance of this, and I'm really trying to say to you that we need to get to consensus on the importance of this now, because I believe it is truly imperative to your feasibility and viability in a very tough competitive funding environment. And I feel it's TCCN's job to help make this easy and move forward in this direction so that we can all succeed together. The next thing we did, which is also not going to be live, is to have a poll everywhere activity. It's a wonderful way for us to capture information about what audience members are thinking and feeling, and we can do it in an anonymous way. So this was a test, and then we said, if you were stranded on an island and could choose one famous person, who would you want to be with? And people using their smartphones can let us know. And obviously we had some wonderful responses. And it was just to show we could all do it. Then we did one. The question was, TCC and its members need to build a strong body of evidence. 25 people were in the audience that took the poll, and 100% of them agreed with that. So on to the safety net. This is, again, from 2017. The data on the right shows the percent of members that agreed that TCCN's job is to restore the TN safety net fund to its historic levels. Fully 67% said that's non-negotiable, and another 22% said very important. So only 5% thought it was moderately or not even important, which is interesting because only 64% of TCCN members receive these funds. So that means 36% of TCCN members don't receive safety net funds, but they get how critical those funds are to their sister organizations, and many of them would like to receive funds, but they were too late in the application process. And due to low funding, there are no new grantees being accepted. So that's a very hard thing, where some of our members receive minimal amounts of funding through the safety net fund, and others who would like to have it do not. Now, let's face it, there are some members who never want it, and that's great too. We're the big tent. Everybody is moved and operated by their mission. So we instituted a new methodology at the time that I came in a year and a half ago. And the new methodology means that no money is left on the table, which is a good thing. We used to always have a carryover fund because it was impossible for the safety net clinics to fully expend the money due to the methodology. That's changed. Now we fully expend it in every quarter, and so there's no money to carry over. And that's a little harsh, actually. It's a hard reality that we're living with this year and we're learning from. The safety net fund level is at a historic low. Despite a $1 million appropriation, we were successful in securing last year, thanks to your fantastic advocacy. So what we've learned this year is the more encounters, essentially, the lower the per encounter rate that a grantee receives. So there's a lot that we're learning, and the department is learning with us. They're great members. I want to take a moment just to say thank you to the Tennessee Department of Health for being a wonderful partner to us. I might have called them a member, but they're a partner. And they are very transparent with us and trying very hard to understand the impacts and find the way forward to be as fair and equitable with these funds as possible. So for our share of the safety net fund total, which is typically 1/2 of the total because the other half goes to the federally qualified health center partners, we actually had some carryover that year, last year, and so we got 5.7 million, say, on the left. And you can see how it was distributed across Project Access, the dental providers, and the primary care providers. And then on the right, it shows the total number of reported encounters. And I can assure you, these are much lower than the actual because, again, 36% of our members don't even report numbers here. As well, there are members out there, there are providers out there that are not members. So we know more is happening than all of that in terms of the encounter level. So this is a slide showing that it works out essentially to about $25, which is where it was for primary care. Dental per encounter. Dental is down from where it used to be, which was $30, to about 28. So not terrible, really, given that the whole safety net came down 20%. We expect to see a reduction in the per encounter payment. Project Access, which has a different reporting and counting methodology, came down pretty significantly. So we're still learning, as I said. But there's good news about the safety net. First of all, the Tennessee Department of Health did not recommend a cut to the safety net fund budget, and we're grateful for that. As I mentioned, they're a great partner for us. They work very collaboratively, and all of us are very aligned in wanting a fair and consistent methodology. This year, Tennessee Charitable Care Network and our partners will be returning to the legislature asking for a total of $12.5 million. What is in the budget, I believe it's $8.4 million from the Tennessee Department of Health. We have a new governor. We don't know, maybe he'll change that and add more so we can, ask the legislature for a slightly smaller appropriation. But we'll be back at it, and it's time for us to start really preparing to communicate with our new legislative representatives and our ones that we're still with us from last year. So on to the advocacy strategy. This was the sing-along portion of our regional meeting where we all sang, "Make new friends, but keep the old. One is silver and the other is gold." We all know that song, and that's where we are in Tennessee. So we're going to stick with the strategies that we've developed. They're good strategies. They're effective strategies, and that is to put a face on the need. Remember that, put a face on the need. You want to get to know your new representatives and to work with your existing representatives that are serving again this term. Work with them even better. We want to reach out to them. We want to educate them. We want to invite them over and introduce them to your fantastic work and to your patients that are otherwise without any place to turn for the services that you're providing. We want to use both facts and stories, and this year we have a fantastic treasure trove of data put together by our partner, the Sycamore Institute of Tennessee. This Sycamore Institute is Tennessee's nonpartisan public policy think tank. They've developed Tennessee County profiles, and I'll show you in this next slide what they look like, but the link is there. Everybody needs to go and learn about their counties and share this information with their legislators. So this is Grundy County, and obviously you can't see the detail here, but you can see there's a lot of detail about health indicators and statistics for each county. So if you have a multi-county service area, you can put together that picture. If you want Sarah and me to work with you to do that in advance of the session so that you can be prepared to educate your legislators, we would love to do that. This is the work that needs to be done, and the time is now. So thank you, Sycamore Institute, for providing it. So now we're going to talk about things that are hard to talk about, like what does TCCN really stand for? Okay. Taking a stand for voting. Why would Mary Kiger even raise this? We're not in the business of encouraging people to vote. Well, let me tell you the sad facts. Tennessee ranks 50th in voter turnout. And among the least likely to vote are low-income Tennesseans, our patients. The people we serve, the people you serve, are among the least likely to vote. But decision makers tell us repeatedly they only want to hear from people that vote. You know, they get voted in and they get voted out, so the voter counts. And we know that it's easy to ignore the poor because when they don't vote, they don't have a voice. But here's some good news. Happy facts. Research shows that people who vote have better health outcomes. They have a lower prevalence of depression and social isolation. Think about all of the shootings we have. This is really a reflection of very isolated, disengaged population, and we want to stop that. We want to reduce that. We want to help lower the risk of early death, and voting is associated with lowering that, as well as with better self-reported health and a tendency to take better care of yourself, both in terms of eating well and not participating in risky behaviors. So good stuff. But why should TCCN care? And why should you use any energy to integrate the question, do you need help registering to vote today, into your registration or your checkout process? Or why should you take another strategy? There are so many to integrate the option to help someone register into the service you're providing. Well, the real important answer is because your patients trust you. And if you think about it, they really don't trust an awful lot of people. There are not a lot of organizations and institutions that the disenfranchised, low-income people in Tennessee turn to with trust, but they do turn to you. So the reason we need to be part of this is because we want to make our patients healthier, and we want to help them have a voice, and they can also speak with greater authority and credibility to the wonderful work you're doing. So how can we do it? There are lots of different ways to do it. Part of it is just starting with the conversation that, hey, part of your health if you're eligible to vote, is to become a voter. That's just part of good health. It's part of good citizenship. It's an American value. You may not be eligible to vote, but if you are and you're not registered, we can help you. And it literally takes maybe a minute to have that talk, and it takes maybe another minute or two or maybe three to actually help them register. And if you're interested in that, we'll show you how to do it and integrate it. It's a wonderful way to help improve the health of your patients. Here's another hard topic, TennCare work requirements. Now, this one was decided early by the Public Policy Committee and then endorsed by the Board of Directors. We took a stand against TennCare work requirements when they were proposed. But why should we have taken that stand? Well, the answer is here in the data from the 2017 survey we did, where TCCN members told us that TCCN's job is to advocate for policy initiatives that reduce the number of Tennesseans who lack health insurance. 50% said it's non-negotiable, 35% said it's very important. So right there, you already have 85%. And the remainder said it's moderately important, but nobody said it's not important. So that's very interesting, and it's important. Why can't we sit this out? Well, we know that disenrollment swells the ranks of the uninsured. We also know that the free and charitable clinic sector can't meet all of the need that it's facing now, and there are programs that really fear being overwhelmed. It's also poor stewardship of limited state dollars. The fiscal note on this initiative was extremely negative, but it was ignored. It essentially said it would cost way more to track down the one or two, the small proportion or number of people that are abusing Medicaid benefits than to simply provide them. It's extraordinarily expensive when, as a state, we're ill prepared to do it. And the main reason I think that the Public Policy Committee took this stand was because they recognized that work requirements further disadvantage an already disadvantaged population. So while we're on the topic of stewardship and other hard things, we're going to introduce the elephant in the room, which has to do with Medicaid expansion. This slide is old. Another 3 states have voted to adopt Medicaid expansion. So it makes it 37 according to my numbers. Tennessee has not done that, and it's a topic that will stay on the table because healthcare has really been a primary topic in the election cycle this year. But there are really important points on both sides of this topic. The people that are on the for side say, well, 85% of TCCN members support reducing the number of Tennesseans who lack insurance, health insurance. 63% of all Tennesseans in a randomized Mason-Dixon poll supported it, and this was bipartisan. Tennessee loses $1.5 billion annually for a total loss so far of between $4 and $5 billion. We know that states that expanded have lower rates of safety net and rural hospital closures. And over half the states that expanded had Republican leadership. So it's not a partisan issue, although in Tennessee it's been made one. But the folks who are against it have some really important points too. They say, hey, Tennessee went broke the last time it added to the Medicaid rolls. So Tennessee can't afford it in the long term. Maybe we can do it for a little while, but what if the government pulls the dollars away? We'll be back where we were with thousands, hundreds of thousands being disenrolled. It's a broken system. Don't grow it. We know Medicaid is not perfect by a long stretch. Why would you want to grow something that has such flaws? And then we have members that say it's the church, not the government, that should tend to the poor. And it's not going to happen in Tennessee. We hear that. We had Insure Tennessee, Haslam's proposal, a Republican governor. We had the 3-star commission, which endorsed Insure Tennessee. And, none of that happened. It was all Republican-led. And it didn't happen then, so it's not going to happen now. Why bother? And another good thing people say is, well, it's not going to change how we operate. We're not going to take Medicaid dollars. That's just not who we are. That's not our mission. So we don't care. So why can't TCCN just sit this one out? We have partners and funders who expect us to have a position. And I think more critically than that, if you look at these are pictures of RAM events. And as grateful as I think all of us are for the love and compassion of the providers that show up to provide these en masse healthcare and dental experiences, I think all of us can agree that we would not want this to be the healthcare experience of our loved ones, of our grandmothers, of our mothers, of our sisters and brothers, of our co-workers. This is not how we want Tennesseans to receive care. So I think we can't really sit it out. So then we did another one of the polls. And here, let me read you some of the answers we got to the phrase, when it comes to Medicaid, I think or feel unintended consequences, changes to healthcare insurance should be made at the national level, not differently for each state. Struggle with, quote, access to care versus insurance. Not sure Tennessee can afford it. I feel confused. It's the right thing to do. The politicians are going to have to work it out. Healthcare should be a non-competitive, non-profit service for everyone. I don't fully understand the possible outcomes. Need more information. Mixed feelings. Tennessee needs it. Need it. It's the right thing to do, but unlikely to happen. And taking a strong position can hurt our funding. It's confusing term to most of our patients. It's the right thing to do. All Tennesseans deserve health care. It should be expanded. It's bigger than a for or against conversation. Mixed feelings, confused. Are there enough physicians that will take Medicaid? No. What strings will come attached? It depends on what it looks like. So 24 people participated in this, and it was a really good reflection, I think, of the way TCCN members feel about it. Then we asked, when I hear about safety net funds, I think or feel a blessing, grateful, must have, critical, grateful, grateful, blessing, lifeline, lifeline, still depends on funding and need back to earlier budget level. We need more so every clinic can benefit. We don't want government money, but I support those clinics that depend on it. Lifesaver, it's a lot of work. The clinics get funding needed to help those who aren't. Wait, I messed that up. The clinics getting funding need to help those that aren't. Tremendously helpful to provide services, clinic operations, but future uncertainty. 17 responded to that. What I would like TCCN to do more of is, and very few actually responded to this, share resources, mobilize patients as advocates, funding fillings for wellness, nurturing a learning network, a culture between clinics. We can all be learners and leaders, shared best practices, continued statewide conferences for networking. And we are honored to do all of that. So I want to end with this quote by Mother Teresa, who points out to us that poverty is not made by God. It's not created by God. God does not want anyone to do without. That's not the heart of God. We need to always remember that. And then she said this, the miracle is not that we do this work, but that we are happy to do it. And that is the truth of who TCCN members are. And I'm proud and honored to work for you. Thank you.